In this PowerPoint, we're going to take a look at sleep deprivation, the different types of sleep deprivation and their adverse effects. Let's go on to our next slide. It is not normal to be able to fall asleep during your day. If you feel drowsy during a lecture, when you are bored or driving or at a movie or any time during your normal day, then you have some amount of sleep debt, meaning you have been deprived of sleep and your body needs some sleep. Normal sleep needs, this is determined by the amount of sleep needed for a person to feel wide awake, alert, and at peak level of performance during wakefulness. For individuals, this can vary from 6 to 10 hours. Sleep deprivation, that can be quantitative or qualitative. Quantitative refers to insufficient duration of sleep or insufficient sleep syndrome. Diagnostic criteria for this includes a short nocturnal sleep time, or not much sleep at night, needing to use an alarm clock to wake up, sleeping longer periods on weekends or on days off, and the patient complaining of fewer symptoms while on vacation. All of those would be diagnostic criteria to identify someone as having insufficient sleep syndrome, which is a quantitative type of sleep deprivation. Now, qualitative types would be when someone has fragmented sleep or interrupted sleep, meaning maybe they're spending enough time in bed, but they're waking up more than they should for some reason. Let's go on to our next slide. Let's talk about some different terms and the consequences of some of these different types of sleep loss. Acute total sleep loss is depriving a person of a complete night of sleep. In humans, they have found that depriving a person for one night of sleep can cause their sleep onset to decrease by 60%. This means that if they normally takes a person to fall asleep in 10 minutes, then after one night of missed sleep, they could fall asleep in only 4 short minutes. Animal studies showed that sleep is essential to life and that death occurred in some rats after 11 straight nights of sleep deprivation. Now, humans can live longer than 11 nights with total sleep deprivation, but the lifespan of that person is going to be dramatically reduced if they experience total sleep deprivation, especially in repeated episodes of it. Now, another type of sleep deprivation is called chronic partial sleep loss. Chronic partial sleep loss is reducing the total amount of sleep that someone sleeps over a longer period of time. So maybe during your work week, you can't fall asleep when you'd like to, and maybe you only get 6 hours of sleep a night, but you do that 5 nights a week. That would be chronic partial sleep loss. One study showed that limiting the amount of sleep to an average of 4.98 hours of sleep per night for 7 straight nights affected daytime sleepiness, fatigue, mood, and physical response time. In the same study, they found it took 2 full nights of sleep to return the subjects to normal function. Another study showed that lasted for 2 weeks and restricted subjects to only 6 hours of sleep or less per night. And in this study, they found that subjects' ability to concentrate and think logically was at a level equal to that if they would have been sleep deprived for 2 whole days. Scarier than that, the subjects were unaware of their diminished ability to concentrate and think logically, meaning they made poor decisions or they were forgetful and they didn't even notice that they were unable to think through things and being forgetful. Let's go on to our next slide. Can someone get enough sleep time but be deprived of certain stages of sleep? And the answers to that is yes. When this occurs, it's typically a side effect of a medication. For example, Prozac is a selective serotonin reuptake inhibitor, and it's used to treat depression. And this can actually suppress REM sleep. So those people will actually get REM sleep. Elavil is another example, and it's a tricyclic antidepressant. It also suppresses REM sleep even more than Prozac does. Remeron is a heterocyclic antidepressant, and this does not suppress REM, but it may induce REM sleep, meaning these people can go into REM sleep much easier. So yes, it is possible that some people are being deprived of just special stages of sleep, and that has its own set of consequences. So let's take a look at that. Let's go on to our next slide here. So REM sleep deprivation, this is when someone is not allowed to get REM sleep. It doesn't matter what is causing the REM deprivation, but the following has been found when people are deprived of REM sleep. The next time they are allowed to sleep, they will go into REM sooner, and they will have a shorter REM latency. We actually call this REM rebound. That's when someone needs REM sleep, and so when they get a chance to go to sleep, they go into REM as soon as they can. The reason of this is because REM pressure exists, and it's caused by prior night's amount of REM sleep, as opposed to how long a person has been awake. So it doesn't matter how much you've been awake, it's how much REM sleep you haven't gotten. That's what determines if you're going to, how much REM pressure you have. Some of the symptoms of REM deprivation include increased alertness, and they don't know why this is. It's unexplained, but in studies they found that if a person is deprived of REM sleep during the daytime hours, they actually are more alert. But more importantly than that is they found that people with REM deprivation have decreased pain thresholds, meaning they're more sensitive to pain. But they found that there were no apparent adverse effects on daytime function, meaning they were able to think logically, they had no confusion or memory loss, they were coordinated. So daytime function, if you lose a little REM sleep, you're going to function fine. You might be a little bit more sensitive to pain, but you're going to function okay. Let's go on to our next slide. Now, slow wave sleep deprivation is a little bit different. And remember, slow wave sleep is our N3 sleep. And again, they found no apparent adverse effects on daytime function. So their cognition was intact, they weren't forgetful, they could recall things. But what they did find was, again, there was a decreased pain threshold, so they were more sensitive to pain. They also complained of more generalized discomfort, fatigue, and decreased energy overall. Let's go on to our next slide. Now, sleep fragmentation is a little bit different than REM deprivation or sleep deprivation. The interruption of sleep with frequent, brief arousals characterized by an increase in EEG and occasionally transient increases in skeletal muscle tone. These arousals last 3 to 15 seconds only. These do not cause continued wakefulness, so it's a brief shift in your EEG where your brain looks like it's awake, but you are not completely awake. And they may or may not be able to identify the cause of these arousals. But when this happens, especially frequently throughout the night, we call it sleep fragmentation. The results of these, it has some causes, or it causes decreased daytime function, and it's similar to that of acute total sleep loss. It causes excessive daytime drowsiness. They also found it decreases sleep latency for the next opportunity to sleep. And as a person's sleepiness increases, it's harder to make them arouse. So when they do sleep, they sleep harder, meaning they need more stimulus to wake them up. So sleep fragmentation, very similar to that of acute total sleep loss, makes people super drowsy. And again, they could get a full night's sleep, meaning they could be in bed 8 to 10 hours, but the constant, frequent, brief awakening of their brain causes the sleep fragmentation and causes these symptoms. Let's go on to our next slide. Overall effects of sleep deprivation: excessive daytime sleepiness, short-term memory deficits, decreases in immune function, cardiovascular hemodynamic effects. These people oftentimes have hypertension because of the awakenings. Their blood pressure doesn't get to hit that low like it's supposed to, so this increases their blood pressure overall. It also can disrupt hormone production. Remember, at night, your cortisol levels are supposed to be the lowest, and then when you wake up in the morning is when it starts to rise again, and it's at the highest first thing in the morning. Well, if someone's waking up frequently throughout the night, that cortisol level may not hit that nadir or that low like it's supposed to, and it may start to rise earlier than it should. And that's just one hormone. I mean, it can disrupt many different hormones as well. So these are just some of the very big effects of sleep deprivation, and there are many more. So let's go on to our next slide. Okay, since we're talking about sleep deprivation and all of you are going to be doing the night shift soon, and maybe some of you haven't done that before, I think we need to talk just briefly about shift work and how to cope with it. First and foremost, you want to try to avoid sleep debt. Give yourself 2 nights of unrestricted sleep prior to your work week, and this ensures that you have gotten plenty of rest prior to depriving your body of sleep, if that might happen. One of the best defenses against shift work, or one of the best ways to help a person cope with shift work, is education. Some important pieces of education about this is that sleep loss is accumulative. So if you miss a little bit of sleep on one night, and you miss a little sleep on the next night, and you miss a little bit of sleep the night after that, all of that is going to add up, and that's going to create a sleep debt. And the next bullet point down, you want to try to avoid that. You want to avoid sleep debt if at all possible. Exercise. If working the night shift, this should be done before your evening nap if you take an evening nap. For day shift, typically you should exercise after your shift is over. So there's a difference there. With night shift, you want to exercise before your shift begins, and day shift, you would exercise after. The next bullet point down, I apologize, I didn't get that taken off there. That's for a book that we don't use anymore, so I apologize for that. Napping. Though this is a great tool to help cope with shift work. A 2-hour nap prior to the shift start has been shown to improve sleepiness during their shift. If you can't get in 2 hours, then 45 minutes is also appropriate. The idea of 45 minutes is to prevent going into your deep stage of sleep. And 3, we typically enter our deep stages of sleep 90 to 120 minutes after lights out. So 45 minutes, you get some rest, but you're not getting so deep that when you wake up, you're going to be groggy. Bright lights, you want to avoid bright lights at the end of your shift when you're working night shift. This can help a person fall asleep faster when they go home. Remember, light therapy is something they use when people need to wake up. So if you're just worked all night and you're going home at 7 in the morning, you want to try to avoid those lights so you can get the best sleep possible. Stimulants. Caffeine. The effects of caffeine last anywhere from 3 to 5 hours, but it can last as long as 10 hours in some people. It's best if you use it 1 hour before you expect to be drowsy. So if you typically get tired around 2 a.m., then you want to drink your coffee at about 1 a.m. However, you also want to be careful that you're not drinking too close to bedtime. So if you're going to go to bed at 7, you don't want to drink it within at least 3 hours of that. Another drug that's used as a stimulant is modafinil, and this is used to treat sleepiness associated with shift work. It is FDA approved. It does not increase blood pressure. It has a very low abuse and dependency potential and very few side effects. However, it is comparable to amphetamines as far as mood, fatigue, concentration, logical thinking ability. It just doesn't have the bad side effects that amphetamines had. Melatonin. This is something people use. It's a chemical our body produces. It comes from the pineal gland, and it's used, our body uses it to help synchronize with our circadian rhythm. There's not a lot of good data on it. In fact, some people say that if you use it, it kind of screws up your own body's clock, but the idea is to use it to help you phase shift. So if you're going to bed when the sun's out, if you take some melatonin, that can offset that and try to reset your circadian rhythm for a night shift type of deal. Again, mixed results so far. Let's go on to our next slide. Okay, so we talked about causes of sleep deprivation. We talked about the consequences of sleep deprivation. So how do we assess a person for excessive daytime sleepiness to see if they've been sleep deprived? Sleep diary, this is used to track a person's sleep and wake habits. It's typically required for 7 to 14 days immediately before a polysomnogram. People track when they went to sleep, when they exercised, when they had caffeine, when they smoked, when they awoke for a period of time, and they do this for 7 to 14 days. For the recording technologist, this allows them to ensure that the patient hasn't sleep deprived themselves prior to the study. Some patients, before they come to the sleep lab, they think, oh, I'm never going to sleep there, so I'm going to sleep deprive myself a few nights before. Well, then that gives us inaccurate data. If they do not have a sleep-related breathing disorder that needs treated, then they could be misdiagnosed with another condition. So we really want them to have 7 to 14 days of a normal sleep-to-wake cycles. So when they come into the sleep lab, we're getting valid data. Owl and Lark scale. This is just a scale that you ask people certain questions like what time do they like to wake up, what time would they exercise, what time would you go to sleep, what time of the day would you study, assuming you didn't have a schedule you had to follow. If you could do it at any time in your 24-hour period, when would you do these things? And the results of that will show if someone's more of an owl, meaning they like to be up earlier in the morning, or if someone's more a lark, meaning they like to do most of their activities later in the day. We don't really use that in the sleep lab, but it is a nice little scale just to see what type of person you are. Epworth Sleepiness Scale. This is probably one of the most popular methods to assess daytime sleepiness. It is subjective, and we're going to see an example here in a few minutes, but it does give us a good idea of how sleepy a person feels. The Stanford Sleepiness Scale, that's another method to assess subjective daytime sleepiness. Polysomnography, meaning a polysomnogram or an overnight study. This would be an objective measure of someone's daytime sleepiness. Again, we would look at their sleep latency, see how quickly they fell asleep, and REM latency, how quickly they go into REM sleep. If someone has a polysomnogram and they don't find anything disrupting their sleep, but this person has excessive daytime sleepiness, then they may have the person stay the next day to complete what's called an MSLT, and that stands for Multiple Sleep Latency Test. And what that does is it's comprised of 4 to 5 different naps throughout the day, each of them about 2 hours apart. And the patient's allowed to lay down and sleep or rest for 15 to 20 minutes, and we see how long it takes them to fall asleep and if they go into REM. If someone falls asleep very quickly in each of those naps, then we know they have some significant daytime sleepiness, and if they actually go into REM on those naps, then that tells us there's a bigger problem there. So, MWT is a multiple wake test. This is another objective measure of an ability, but this is an objective measure of a person's ability to remain awake in a situation that's conducive to sleep. So it's slightly different than the MSLT. And then actigraphy, this is used to detect a period of inactivity and activity. It is a quick and cost-effective way to assess a person's sleep-wake cycle. It does not diagnose anything, but it can be used to decide if further testing is warranted. We typically see this in people complaining of insomnia. They say they can't sleep, they can't sleep. If someone has insomnia, there's no point in bringing them to a sleep lab to watch them sleep, because the problem isn't them with their sleep, it's a problem with them being awake. So what they'll do is they'll use actigraphy, which is like a watch, and they wear it on their wrist, and they can record the data for, several days, and then look back at it. It doesn't really tell when the person is asleep. It tells when they were active and when they were inactive, so they can use that to try and guess when the person did sleep. Let's go on to our next slide. Okay, this is the Epworth Sleepiness Scale. And notice it says, how likely are you to doze off or fall asleep in the following situations? Answer considering how you have felt over the past week or so. 0, you would never doze. 1, slight chance of dozing. 2, a moderate chance of dozing. And 3, a high chance of dozing. So sitting and reading, and then the patient would give a number. Watching TV, sitting inactive in a public place like a theater or a meeting, as a passenger in a car for an hour without a break, lying down to rest in the afternoon when able, sitting and talking to someone, sitting quietly after lunch without alcohol, or in a car while stopped for a few minutes in traffic. So the highest score a person could get would be a 24. Anything over a 10 is considered to be significant daytime sleepiness and needs further evaluation. Let's go on to our next slide. This is the Stanford Sleepiness Scale. Using the scale below, indicate the single number that best describes your level of alertness or sleepiness at each time. And so it gives you the numbers and a little description for each one, and then at different times of the day, you're supposed to rate how you feel. Let's go on to our next slide. Owl and lark scale. Again, this kind of tells if someone is more of a morning person or more of a nighttime person, and it kind of goes through what you do each day and what time of day do you like to do it, whatnot. Let's go on to our next slide. The multiple sleep latency test. This is just a little picture of how it works. The first box there, number 1, you wake the patient up in the morning. For about 2 hours, they get to do whatever. Then you recheck your electrodes. At the 2-hour mark, they're in bed, allowed to sleep if they want. Then they wake them back up after about 15 minutes, and that process repeats throughout the day. If a person falls asleep in a half a minute, an average of half a minute over all of the naps that they take, which is 4 to 5 naps, then they're said to have severe sleepiness. If they fall asleep between 5 to 10 minutes on average for each of those naps, then it's troublesome. If it's 10 to 15 minutes that they fall asleep, it's manageable. And if it's 15 to 20 minutes, then they're excellent, meaning they don't really have excessive daytime sleepiness. So this is very, very much averaged. These are not the details that the doctors actually use. It's just an example. Let's go on to our next slide. Oh, you're not going to be able to read this. This is the multiple wake test protocol, and it's 4 trials of 40 minutes each, performed at 2-hour intervals. So they start the first MWT trial 90 minutes to 3 hours after they get out of bed. They put the patient in a chair with a dim light over their head, and it's very specific as to how far away the light is from the patient's head and the position of the chair and whatnot. But they put the person in the chair and they record them for 40 minutes, and with this test, you shouldn't see the patient fall asleep. You're trying to see if they can stay awake when the environment is conducive to sleep. So let's go on to our next slide if we have one. This might be our last one, actually.